A middle-aged, right-hand-dominant constructed worker is seen in the clinic. He had a previous history of a middle one-third to distal one-third shaft of humerus fracture on the right side. He was revealed in emergency room 1 year back and was unable to perform wrist extension and finger and thumb extension. At the emergency room, the physician informed him to continue with the sling and to follow up with the orthopedic clinic. Now he is in the clinic and it has been nearly 1.5 years with unsuccessful rotation of the hand and wrist functions. The patient is quite concerned and is unable to perform his activities of daily living, especially at the hand or the wrist. The clinical scenario is depictive of a radial nerve injury, probably higher radial nerve injury. We start with the physical examination of the patient. Patient has optimal range of motion of the shoulder, has good range of motion of the elbow joint with active flexion of the wrist up to 50 degrees. Although passive wrist extension is full with full supple joint, active wrist of range of motion with extension is not possible. Digital range of motion is tested. The patient was able to flex all the digits of the thumb in interphalangeal joint. He cannot extend his fingers at the level of metacarpophalangeal joint. He has numbness noted over the dorsal aspect of the thumb and the hand. The ulnar and the median nerve innervating muscles are tested and found to be normal. Diagnostic studies are performed which shows radiograph which shows a middle to distal one-third shaft of humerus fracture which has been healed and operated by intermittent nail and is aligned optimally. EMGs were done 4 months back and had shown absent brachioradialis potential. The patient had a new EMG done which also confirms the brachioradialis potential is not present, as well as no response in EDC, extensor pollicis longus, as well as extensor carpi radialis brevis. A differential outline with the nerve injury can be tendon laceration, especially of extensor pollicis longus, tendon laceration of extensor carpi radialis brevis or longus, radial nerve injury, or a mixed nerve injury. A diagnostic assessment is by physical examination, and we have to classify it into high or a low median nerve injury. Radial nerve injury can occur at the proximal one-third of the forearm, resulting in low radial nerve injuries. Low radial nerve palsies are characterized by loss of thumb extension, abduction and finger extension, and by lack of grasp. The level of injury can be easily diagnosed by a hand hanging the wrist. If hanging the wrist is straight, the level is above elbow. If the wrist is in extension but radial deviation, ECRL is intact and the injury is below the elbow. The radial nerve basically originates from the posterior cord of the brachial plexus just above the axilla. The nerve passes posteriorly and laterally in close approximation to the humerus throughout its course. The nerve is protected by a long and the lateral head of the triceps. Fractures such as displace a spiral fracture of the humerus can severely damage the nerve in that area. A sensory branch of the radial nerve becomes subcutaneous just beneath the brachioradialis in the distal forearm. The radial nerve provides motor branches to the tricep, brachioradialis, and supinator, and the wrist, fingers, and thumb extension. The radial nerve provides sensory innervation of the posterior and inferior lateral arm, posterior forearm, and dorsal wrist and hand. The treatment of the fracture with the straight radial nerve and palsy is controversial. An EMG done with revealing non-functional brachioradialis at 4 months interval of the date of injury may require surgical intervention with respect to nerve exploration. Nerve exploration may reveal a stretched nerve or continuous radial nerve, and that may be laceration as well, presumably by the bony spicules. Now, as in our patient, the hand and wrist functions has not been restored, tendon transfer is the preferable treatment. Regarding the non-surgical approach, such as observation of palsies is always indicated in 3 to 6 months interval, and then after surgical management can be undertaken. Preoperative planning is essential for all operative cases, but especially for those involving tendon transfer. The principle of tendon transfer must be adhered prior to a successful tendon transfer. A donor for a wrist extension, a donor for a finger extension, and one donor for thumb extension must be strictly adhered. Passive range of motion of the wrist and finger joints is important and should be supple. Prior to proceed with any elective operative intervention in the form of tendon transfers. There are many forms of high radial nerve palsy options. The transfer is a modified Jones/Boyd operative intervention. It consists of 4 parts. Number 1, pronated to ECRAB. Number 2, flexor carpi radialis to the finger extension, that is EDC. Number 3, palmaris longus for extensor pollicis longus. And number 4, tenodesis of abductor pollicis longus. These donors are preferred as the preferred power grip is present by leaving a flexor carpi ulnaris intact and do not require FDists. On the other, these transfers require 2 excellent wrist flexors in the palmaris longus. If these tendons are not present, the transfer cannot be possible and alternate option should be decided. A skin incision is made at the junction of the upper and the middle third of the radial side of the forearm and extended distally to approximately 3 cm proximal to the radial styloid. The incision moved dorsally to the 4th compartment. A short transfer incision is made over proximal to the volar wrist flexion crease over the FCR and the palmaris longus incision to identify these structures. Now, a pronated radius is identified at the insertion of the mid-shaft of the radius on the dorsal aspect of the forearm and is detached with a 3 cm strip of periosteum. The muscle is then freed proximally to the midline of the forearm. It is essential that slow and meticulous dissection should be performed to maintain a good length while attempting to suture this strip to the ECRB. With the palmaris longus and the FCR transected at the wrist and freed proximally to the mid-forearm, both tendons are moved dorsally through a subcutaneous dissection opened up with a hemostat. Now, the ECRB is cut at the mid-forearm and the wrist is held at 50 to 60 degrees of extension. The pronated is then sutured to the ECRB without tension. The wrist should move into 30 degrees of wrist dorsiflexion when placed against gravity and flexion with the tenodesis effect. The remaining part of the procedure, that is finger extension and thumb extension, is then completed. If prior to beginning the finger extension and thumb extension, the wrist has a slight position of ulnar deviation due to loss of FCR, suturing must occur onto distal end of the ECRL with some tensioning of the distal aspect of ECRB to compensate. The ADC as well as extensor minimi quinti are cut at the forearm levels. It is important to not include the extensor insidis proprius in this transfer. The flexor carpi radialis is split and sutured at each tendon separately. The tendon length is checked by using the tenodesis effect with palmar flexion of the wrist and observation of full finger extension. With the wrist in full dorsiflexion, fingers should be able to flex fully at a position of function. The 3rd compartment of the wrist is now opened and the extensor pollicis longus is freed. The tendon is cut 5 cm to 7 cm proximal to the radial styloid and sutured to the palmaris longus. With the thumb metacarpal metacarpal joint in 20 degree of flexion and wrist in 30 degree of extension. The distal end of abductor pollicis longus is looped around brachioradialis, just proximal to the radial styloid. The abductor pollicis longus is then sutured to itself, and the brachioradialis is with the first metacarpal held in extension and the wrist in 30 degree of full extension. This tenuous effect is completed to make certain no restricted wrist motion is seen. If full ulnar deviation of the wrist is restricted by the tenuous effect, the abductor pollicis longus is loosened to appropriate tension. The tourniquet that is used at the beginning of the procedure is downed, hemostasis is obtained, and the wound is closed. The arm is placed in volar splint to hold the wrist in 45 to 50 degree of dorsiflexion. The finger should be positioned in 30 degree of palmar flexion at the metacarpophalangeal joint and at the proximal and distal interphalangeal joint, and the thumb placed in abduction of 30 degree of flexion and metacarpo-interphalangeal joint as well as on 30 degrees. At approximately 4 weeks, the splints are removed and the volar custom splint is being applied with a hand therapist referral. Active range of motion exercise of the fingers are begun at 3 to 4 weeks and the wrist at 6 weeks. Splinting up as protection is done up to 8 to 12 weeks and often yield good results. Regarding alternative procedures, patients who develop wrist contractures should consider undergoing wrist arthrodesis rather than tendon transfers. Patients with multiple nerve injuries and insufficient tendon donors to allow for tendon transfer should also be considered for wrist arthrodesis. Patients who have totally disabled who do not want surgical intervention or are not compliant can usually be splinted with a custom-made certified occupational therapist hand referral. When you talk about complications in such corrections of radial nerve palsy are high. There are several, and overcorrection or undercorrection and soft tissue bed problems can occur. Overcorrection is one of the most common complications in this transfer. Overcorrection of the wrist drop may be due to excessive shortening, that is, too much tension on the wrist on the transfer. This complication can easily be resolved with testing the hand in the operating room with the tenuous effect. When overcorrection is present due to adherent tendon transfer, passive palmar flexion of the wrist will be limited. The transfer should be re-explored and the tendon lengthened if not recognized intraoperatively. It is important to note that if peroneal teres was used as a tendon donor, it may prove very difficult to lengthen this tendon transfer at a second return visit to the operating room. Undercorrection of the wrist drop is usually due to the transfer that has been sutured too long. To test the transfer length with the patient in the postoperative wrist drop, the patient forearm is supinated, so the ulnar side of the wrist is parallel to the examination table. If active wrist dorsiflexion does not improve, the tendon requires shortening. Shortening the tendon by 1 centimeter can increase dorsiflexion by 15-20 degrees. To achieve more dorsiflexion with the peroneal teres, the ECRB is sutured more distally. If the wrist can dorsiflex with gravity eliminated, the patient problem is probably one of the muscle imbalance and not a technical error, usually such as suturing too long. Contracture of soft tissue bed with resultant failure of the tendon transfer can be avoided. Adhering to the general principles of tendon transfers often lead to good results.